There is a moment that happens quietly in the body after 60, and most people never feel it coming. The same pill you have been taking for years, the one your body tolerated without issue for a decade, can suddenly begin to behave differently. Not because the pill changed, but because your body did. And in some cases, that difference is not small. It can mean the difference between protection and risk, between stability and a slow buildup towards something far more serious. What makes this especially dangerous is that nothing feels wrong at first. No warning sign, no pain, no clear signal, just a silent shift in how your body processes, responds to, and is affected by substances it has been handling for years. And today, we are going to talk about 5 specific types of medications that after the age of 60 have been linked to an increased risk of cardiovascular events, particularly heart attack and stroke, especially when certain conditions are present or when they are taken at the same doses and in the same patterns established years earlier. Here is the part that matters most. This is not about fear. This is about understanding what is actually happening inside your body so you can make better decisions and have more informed conversations with your doctor. To understand why these risks increase after 60, you have to start with something most people are never clearly told. Your body does not process medications the same way it used to, and this is where everything begins to change. As we age, several systems in the body slow down. The liver, which is responsible for breaking down many medications, becomes less efficient. The kidneys, which filter waste and excess substances from the blood, lose some of their filtering capacity. That means drugs stay in your system longer, sometimes much longer than expected. And when that happens, even a normal dose can begin to act like a higher dose over time, with effects accumulating in ways that were not anticipated when the prescription was originally written. But that is only part of the story. There is also a shift in how your blood vessels respond. Your arteries become less flexible. The inner lining of your blood vessels becomes more sensitive. Circulation patterns change, and the balance between clotting and bleeding becomes more delicate. So when a medication interacts with any of these systems, the effect can be amplified in ways that would not have occurred at a younger age. This is where people get misled. Because the medication itself is not necessarily dangerous, it may have been completely appropriate when it was first prescribed. It may still be useful today, but the context has changed. And medicine is all about context. The same drug can be helpful in one situation and risky in another. The same dosage can be appropriate at 50 and excessive at 70. And yet, in real clinical practice, prescriptions are often continued for years without the kind of detailed reassessment that the body's changing physiology genuinely warrants. After 60, the baseline risk of cardiovascular events like heart attack and stroke naturally increases. That is a known biological reality. But when certain medications are layered on top of that baseline, especially without adjustment for how the body has changed, they can push that risk higher. Sometimes subtly, sometimes significantly, and often without any obvious symptoms until something happens. That is why understanding this matters, not to create anxiety, but to create awareness that leads to better questions and better outcomes. The first medication category is one of the most commonly used groups of drugs in the world, non-steroidal anti-inflammatory drugs, widely known by the abbreviation NSAIDs. This includes medications like ibuprofen, naproxen, and stronger prescription-strength anti-inflammatory drugs. They are taken for joint pain, back pain, arthritis, headaches, and everyday inflammation. And for many people, they feel like a simple, reliable solution. But inside the body, something beyond pain relief is happening. NSAIDs work by blocking a group of enzymes involved in producing inflammatory compounds called prostaglandins. That is what reduces pain and swelling. But those same prostaglandins also play a role in protecting blood vessel walls and maintaining normal kidney function. When NSAIDs interfere with that system, 2 things can happen that directly affect the heart. First, blood pressure can rise. The mechanism is well documented. NSAIDs can cause blood vessels to constrict, partly through their effect on prostaglandin pathways, and that constriction pushes blood pressure higher. This effect may be modest in a younger person with elastic arteries, but after 60, when arterial flexibility has already decreased, even a moderate blood pressure elevation adds meaningful load to the heart. Second, NSAIDs can cause the kidneys to retain more sodium and water. That fluid retention increases blood volume, which in turn increases the work the heart must do with every beat. When you have both elevated blood pressure and increased fluid load occurring simultaneously, the cardiovascular strain compounds. Multiple large-scale studies, including analyses drawing on data from hundreds of thousands of patients, have confirmed that long-term or frequent NSAID use is associated with an elevated risk of heart attack and stroke, particularly in older adults or those with existing cardiovascular risk factors. The U.S. Food and Drug Administration updated the labeling on all prescription NSAIDs in 2015 to reflect this risk more prominently, noting that the risk increases with duration of use and that even short-term use can carry some risk in patients with existing cardiovascular disease. This does not mean NSAIDs must be avoided entirely after 60. Short-term use for a specific acute condition, monitored carefully and limited in duration, may be entirely appropriate. But daily, long-term use without periodic reassessment of whether the cardiovascular trade-off remains favorable is where the risk genuinely accumulates. The second medication category is proton pump inhibitors, commonly referred to as PPIs. These include omeprazole, esomeprazole, lansoprazole, and similar drugs. They are prescribed for acid reflux, gastroesophageal reflux disease, peptic ulcers, and stomach protection for patients taking other medications that can irritate the gastrointestinal lining. On the surface, they seem straightforward. They reduce acid production, relieve discomfort, and protect the stomach. The cardiovascular concern with long-term PPI use is more indirect than with NSAIDs, but it is real and supported by a growing body of evidence. PPIs reduce stomach acid significantly, and stomach acid is necessary for the proper absorption of several key nutrients. Specifically, long-term PPI use is associated with reduced absorption of magnesium, calcium, and vitamin B12. The FDA issued a safety communication about PPI-related magnesium deficiency as early as 2011.
Why does this matter for the heart?
Magnesium plays a critical role in maintaining stable heart rhythm. Low magnesium levels are associated with an increased risk of cardiac arrhythmias, including atrial fibrillation, which is itself a significant risk factor for stroke. Calcium balance is involved in vascular smooth muscle function and blood pressure regulation. Vitamin B12 deficiency, when sustained over time, contributes to elevated homocysteine levels in the blood, and elevated homocysteine is an independently recognized risk factor for cardiovascular disease and stroke. Beyond the nutrient pathway, observational studies published in journals including PLOS ONE and JAMA Internal Medicine have found associations between long-term PPI use and increased risk of heart attack and stroke, though establishing direct causality in this population is complicated by the fact that people on long-term PPIs often have multiple other health conditions. The American Gastroenterological Association has noted that while PPIs are appropriate and important for specific conditions, many patients are continued on them long-term without periodic reassessment of ongoing need, and that practice carries incremental risks that deserve attention.
The critical point is this.
Many people are started on a PPI for an acute issue and then continue taking it for years because it seems safe, was prescribed by a doctor, and causes no obvious discomfort. But the longer it continues without formal reassessment, the more any underlying effects on nutrient balance and cardiovascular function accumulate. The solution is not automatic discontinuation, but periodic, structured review of whether the benefits still clearly outweighs any risks for each individual patient at their current age and health status. The third medication category involves drugs that act directly on the central nervous system, benzodiazepines. Examples include diazepam, lorazepam, clonazepam, and alprazolam. They are prescribed for anxiety, insomnia, muscle spasm, and certain seizure disorders. They are effective at what they do, providing rapid relief from anxiety and facilitating sleep. And for many people, they feel like an essential support, particularly in the later decades of life when both anxiety and sleep disorders become more common. The connection to cardiovascular risk from benzodiazepines is more indirect than with the first two categories, but the pathways are real. After 60, the body becomes more sensitive to these medications because they are metabolized more slowly, they accumulate more easily, and their sedative effect strengthens at the same dose over time. This produces a constellation of effects that indirectly stress the cardiovascular system.
The most significant indirect pathway is reduced physical activity.
Benzodiazepines cause sedation, reduce initiative, and lower motivation for movement. Over weeks and months of regular use in an older adult, this can translate to substantially less daily physical activity. And physical activity is one of the most powerful protective factors for cardiovascular health. Reduced movement decreases the efficiency of circulation, increases the risk of blood clot formation in the deep veins of the legs, and removes one of the primary drivers of cardiovascular fitness. A second indirect pathway involves sleep-related breathing. Benzodiazepines suppress respiratory drive, and in people with existing or unrecognized sleep apnea, they can worsen nighttime oxygen desaturation. Repeated episodes of low blood oxygen during sleep place significant stress on the heart and are independently associated with elevated risk of arrhythmia, hypertension, and cardiovascular events.
Epidemiological studies have found associations between long-term benzodiazepine use in older adults and increased rates of falls, cognitive decline, and cardiovascular events, though disentangling causality from correlation in an elderly population with multiple conditions is methodologically challenging. What the evidence does clearly support is that long-term use in older adults carries risks that frequently outweigh the risks for younger patients taking the same doses, and that periodic reassessment of continued need is a clinical priority that is often not adequately performed. The fourth category includes decongestants and stimulant-type medications, particularly those containing pseudoephedrine, phenylephrine, or similar sympathomimetic compounds. These are found in cold remedies, allergy medications, sinus relief products, and combination over-the-counter formulations. Their widespread availability and over-the-counter status create the impression of inherent safety, but their mechanism of action is directly relevant to cardiovascular risk. Decongestants work by activating adrenergic receptors that cause blood vessels to constrict. That constriction reduces swelling in the nasal passages and sinuses, which is the intended therapeutic effect. But the same receptor activation occurs throughout the body's vasculature, not just in the sinuses. The result is a generalized increase in vascular resistance, which drives blood pressure up and increases the workload on the heart. In a younger person with elastic responsive arteries, this effect is usually transient and well tolerated. But after 60, when arteries are already stiffer, when blood pressure is more likely to already be elevated, and when the cardiovascular system has less reserve capacity, even a modest additional increase in resistance can push someone into a problematic range. The FDA and the American Heart Association both recommend that people with high blood pressure, heart disease, or a history of stroke discuss decongestant use with their physician before taking these medications. The risk compounds in combination. Many older adults are taking a blood pressure medication, a pain reliever, a stomach acid reducer, and potentially something for sleep. And then during cold and allergy season, a decongestant is added without anyone performing a formal drug interaction assessment. Each individual medication may be within a technically acceptable range, but the cumulative effect on blood pressure, fluid balance, and cardiovascular workload is more than the sum of the individual parts. This is the interaction risk that is most frequently underestimated by patients and sometimes underappreciated in clinical settings. The fifth medication is the one that tends to surprise people most, precisely because it is so widely trusted and so universally considered benign. For decades, low-dose aspirin was recommended almost universally for adults over a certain age as a simple, inexpensive way to reduce the risk of heart attack and stroke. The reasoning was straightforward.
Aspirin reduces the ability of platelets to clump together, which decreases the likelihood of the arterial clots that cause most heart attacks and ischemic strokes. And this reasoning, in the right clinical context, remains valid. The problem is that aspirin's benefits and risks are not symmetric across all populations, and they are not constant over time. In 2022, the U.S. Preventive Services Task Force issued updated guidance reflecting a major shift in the evidence base. For adults age 60 and older who have not had a previous heart attack or stroke, the task force now recommends against the routine initiation of low-dose aspirin for primary prevention of cardiovascular disease. This recommendation change was based on accumulating evidence that in this age group, the harms of aspirin, primarily increased risk of serious internal bleeding, begin to outweigh the benefits for those without established cardiovascular disease. The mechanism behind this shift is important to understand. Aspirin reduces platelet aggregation throughout the body, not just in the coronary arteries. After 60, the lining of the gastrointestinal tract becomes more fragile and more susceptible to bleeding. The lining of small blood vessels in the brain also becomes more fragile. Clotting is not only a harmful process, it is also a protective one, the body's mechanism for stopping bleeding when vessel walls are damaged. When aspirin suppresses clotting capacity in someone with fragile vessels, the risk of gastrointestinal bleeding and hemorrhagic stroke, the kind caused by bleeding in the brain rather than by a clot, increases. And for someone without prior cardiovascular disease, that added bleeding risk may not be offset by a meaningful reduction in clot-related events. This is not a uniform recommendation against all aspirin use after 60. For people who have already had a heart attack or stroke, or who have specific high-risk conditions that their cardiologist has identified, aspirin may remain an important part of their treatment. The change in guidance applies specifically to the practice of routinely taking aspirin as a preventive measure simply because of age, without a specific clinical indication supported by an individual risk assessment. The many millions of adults who started taking a daily aspirin based on older guidelines and have simply continued without reassessment represent exactly the population the 2022 guidance was intended to reach. What all 5 of these medications have in common is not that they are inherently dangerous, but that their risk-benefit balance is more sensitive to the context of an aging body than most people, and sometimes most prescribers, recognize in day-to-day practice. The real issue is taking them the same way while the body is no longer the same. Understanding what to actually do with this information matters more than the knowledge alone. The most important practical step is initiating a formal medication review with your physician or pharmacist. Not when something goes wrong, but proactively. This means bringing a complete list of everything you take, including over-the-counter medications and supplements, and asking explicitly whether each item is still appropriate at your current age, your current health status, and your current combination of other medications. The question, "Do I still need this at the same dose?" is one of the most clinically valuable questions an older adult can ask, and it is one that is frequently not asked because people assume the prescribing decision is the physician's job to revisit, while physicians assume the patient would raise it if anything seemed wrong. The result is a gap that persists for years. Pay attention to combinations, specifically. Most of the cardiovascular risks described here are not from any single medication taken in isolation. They emerge when multiple medications are taken simultaneously, each shifting some aspect of blood pressure, fluid balance, clotting, or cardiovascular workload, and the combined effect exceeds what any individual drug assessment would predict. Over-the-counter medications and occasional use drugs deserve the same scrutiny as daily prescriptions because they enter the same physiological system. Watch for subtle signals rather than waiting for dramatic ones. Mild but persistent increases in fatigue, shortness of breath during activities that previously felt easy, changes in blood pressure readings at home, new lightheadedness when standing, or alterations in sleep quality are often early indicators that something in the system needs adjustment. They are not proof of a serious problem, but they are clinically meaningful signals that warrant a conversation rather than dismissal as normal aging. Finally, understand that your body is not static, and neither should your medication regimen be. What was appropriate at 55 genuinely may not be optimal at 68, not because anything went wrong, but because the body's physiology has continued to evolve. Medications are tools. Like any tool, they need to be matched to the job that currently needs to be done, with the equipment currently available. Regular reassessment is not overcaution. It is the responsible management of a system that is continuously changing. The difference between reacting to a cardiovascular event and preventing one often comes down to small adjustments made early, before the system reaches a critical threshold. Not one dramatic intervention, but a series of informed, proactive decisions that keep the body's balance maintained as its needs evolve. That balance is something you have more influence over than most people realize. Not through fear or constant worry, but through awareness and the habit of asking the right questions at the right time. There is a broader principle embedded in everything discussed above that deserves direct articulation, because it applies well beyond these 5 specific medications. Modern medicine is extraordinarily good at identifying treatments for conditions. It is somewhat less systematically good at revisiting those treatments over time as the patient changes. This is not a criticism of physicians, who work under significant time and resource constraints in most clinical settings. It is simply a structural reality of how healthcare systems function, and understanding it helps explain why the responsibility for initiating reassessment often falls to the patient. Prescribing medicine is one decision made at one point in time, based on the patient's health status at that moment, the evidence available at that moment, and the clinical guidelines current at that moment. All 3 of those factors change. The patient's physiology changes with age. The evidence base evolves, sometimes significantly, as demonstrated by the aspirin guideline reversal in 2022, and clinical guidelines are updated as new research accumulates. But the prescription continues on autopilot unless someone actively revisits it. That someone is most reliably you. This dynamic is particularly pronounced with medications that cause no immediate discomfort when they are potentially contributing to harm. NSAIDs suppress pain effectively, so they are continued. PPIs prevent acid reflux symptoms, so they are continued. Benzodiazepines reduce anxiety and promote sleep, so they are continued. Decongestants clear congestion, so they are reached for seasonally. Low-dose aspirin causes no symptoms at all, so it is continued indefinitely. In each case, the absence of an obvious problem is mistaken for confirmation that there is no problem. But the cardiovascular mechanisms described here do not announce themselves through symptoms until they have accumulated enough to produce an event. The concept of polypharmacy, which refers to the simultaneous use of multiple medications, is one of the most actively researched areas in geriatric medicine for exactly this reason. Studies consistently find that as the number of medications increases, the likelihood of clinically significant drug interactions, adverse effects, and harmful physiological combinations increases disproportionately. The risk is not linear, it compounds. And older adults are, for entirely understandable reasons related to having accumulated multiple chronic conditions, the population most likely to be taking the largest number of medications simultaneously. Some healthcare systems have begun to address this through structured medication review programs specifically designed for older adults, in which a physician or clinical pharmacist systematically evaluates every medication a patient is taking and actively considers whether each one is still indicated, whether the dose is still appropriate, and whether any combination effects have accumulated that need to be addressed. These programs have been shown in research to reduce adverse drug events, hospitalizations, and in some cases mortality. If your healthcare provider or health insurance plan offers this kind of review, it is worth actively requesting it rather than waiting for it to be offered. If it is not available, asking your pharmacist for a medication therapy management session, a structured service that many pharmacists are trained and authorized to provide, can accomplish much of the same purpose. The practical question of how to prepare for such a review is also worth addressing. Bring a written list of every substance you take, including prescription medications, over-the-counter products, vitamins, minerals, and herbal supplements. Include the dose and how often you take each one. Note which medications you take every day versus occasionally. Include anything you have started in the past year, and also note anything you have stopped taking on your own. This preparation significantly increases the quality and efficiency of the review conversation.
When you are in that conversation, the most productive questions to ask are not just, is this safe? But more specifically, has anything changed in my body over the past year that might affect how this medication works? And are there any interactions between the medications on this list that I should be aware of? And is there a lower dose or a different formulation that might carry less risk for someone my age? And are there lifestyle changes that might reduce how much of this I need to take? These questions move the conversation from simple continuation to active optimization, and they often produce clinically meaningful adjustments. For the specific medications discussed here, there are some particular questions worth raising. With NSAIDs, the key question is whether there is a non-medication alternative, such as physical therapy, topical formulations that reduce systemic absorption, or a different class of pain management that might achieve the same pain control with less cardiovascular impact. With PPIs, the key question is whether the original indication for acid suppression still exists, or whether the medication has simply been continued as a precaution beyond its originally intended duration. With benzodiazepines, the key question is whether a structured tapering plan with simultaneous introduction of behavioral approaches to anxiety and sleep, such as cognitive behavioral therapy for insomnia, might reduce dependence and eliminate the long-term cardiovascular and cognitive risks. With decongestants, the key question is whether there is a non-sympathomimetic alternative for the underlying condition, such as nasal corticosteroids for chronic nasal congestion, that would not carry the blood pressure risk. And with aspirin, if you are in a category of adults over 60 who have been taking it for primary prevention without a specific cardiovascular diagnosis, the key question is whether your physician has reviewed the 2022 guideline changes and assessed whether that recommendation applies to your individual situation. None of these conversations require confronting your physician or questioning their competence. They require participating actively in your own care with the informed awareness that your body is changing, that the research base is evolving, and that medications are most effective and safest when they are matched precisely to the current clinical context, rather than continued indefinitely from a decision made years earlier. That active participation is not a burden. It is one of the most meaningful things you can do for your long-term cardiovascular health, and it costs nothing beyond the willingness to ask. One final point deserves emphasis before closing, because it connects the entire framework of this discussion to something more immediate and actionable. Everything covered here operates within a broader principle about preventive medicine that is often stated but rarely internalized. The time to address a risk is before it becomes an event, not after. Heart attacks and strokes do not usually arrive from a clear sky. They are the culmination of a process that has been developing over months or years through exactly the kinds of accumulated, compounding physiological changes described throughout this discussion. The medications that interact with those processes are not the sole cause, but they are factors that can accelerate or amplify what might otherwise have remained below the threshold of a clinical event. The goal of understanding all of this is not to add another source of anxiety to daily life. It is to shift from passive medication management, where you continue taking what you are prescribed and hope nothing goes wrong, to active engagement with your own pharmacological environment, where you periodically ensure that what you are taking still makes sense for where your body is right now. That shift is not difficult. It does not require medical training. It requires only the awareness that your medication needs are not fixed and the habit of asking the questions that keep your regimen current. After 60, the body deserves that kind of attention, not because it is failing, but because it is a sophisticated, evolving system that benefits from care that is as dynamic and responsive as the system itself. The 5 medications discussed here represent 5 areas where that responsiveness can make a genuine, measurable difference in long-term cardiovascular outcomes. The conversations those medications should prompt are among the most valuable you can have with your healthcare team, and the knowledge that makes those conversations productive starts exactly here, with understanding what is actually happening and why it matters.